through this discussion briefly and touch on the highlights, the main figure, the main message. It's again a comparison of exercise versus medication versus placebo, specifically in individuals with coronary heart disease. So these are individuals that have had prior myocardial infarction, they've been treated, they're not currently undergoing surgery, they're safe and cleared for exercise. And now this is an observation of whether medication, sertraline, like before, Zoloft, the SSRI that we talked about on Tuesday, is as effective or more effective than exercise. So the context of this paper is medication's really good, is something else a surrogate for medication. So this is leading the charge. Medication is leading the charge in this case. And so in these individuals, they embarked on a 16-week intervention in either an exercise group or a Zoloft sertraline group or a placebo group. And the exercise is similar, it's typical to what you've seen in class, 3 days a week, 30 minutes per day, 75 to 80% of heart rate reserve. And this is supervised exercise, 94% adherence rate. So no questions about whether the exercise was effective or not. And exercise for these people with a chronic condition, a comorbidity, was absolutely the most effective at decreasing, again, Hamilton Rating Scale of Depression scores. HAM-D, HRSD, like you've seen in your papers, the self-reported questionnaire scores that evaluate depressive symptoms. This is the main figure that I'm showing you. This is after 16 weeks. The scatter points are all the individual data. The mean and 95% confidence intervals are shown here. Exercise in blue, sertraline in the middle in yellow, and then placebo on the right in red, and lower scores better. Exercise has a lower score. I always want to know baseline because this is one snapshot in time. It doesn't tell us the change or the delta. And if you look through the paper, you see similar baseline scores. They're all high. They're all above 8. They're all majorly depressed according to this scale. After the intervention, certainly the exercise, the majority is in remission, a score under 8. It's arguable if sertraline is under 8. Placebo seems to not be affected very much, but a large decrease in all groups from baseline. You might argue the exercise group started with 1 point less on the HAM-D rating scale, and it's possible that does contribute to the extra drop in exercise, but I would imagine if we corrected for that baseline score, you'd still see a divergence or a separation between these two groups. That's not been done, so that's one point of consideration in this study. But some of the intangibles outside of this graph I think are pretty important. Exercise minimized major depressive disorder and improved remission. Fantastic. It also minimized sex-related side effects and fatigue-related side effects, which I think are also nice side effects that you would want to have in a treatment for depression or coronary heart disease. And let me just read what they said in the paper quickly. 20% of patients receiving sertraline reported worse post-treatment fatigue compared with 2% in exercise, 9% in placebo. Exercise far less fatigued than the other two groups. That's a check for exercise. 26% in the sertraline group reported increased sexual problems compared with 2% in the exercise and 12% in placebo. Again, probably a check for exercise. So there are intangibles here that add to the effectiveness of exercise that aren't immediately borne out in the depression data. And being that this was from the point of view of medication is key, is anything else a surrogate, really what we conclude from this is we absolutely know medication was no better than exercise. It seems that for depression, exercise is the most beneficial, but because of the small discrepancy in baseline, I'm not asserting exercise is better universally, but just sertraline is no better than exercise. They're both better than placebo. I still think that the side effects plus the accentuated drop in HAM-D scores with exercise puts that over the top, makes that a little bit, makes that a better therapy. but it is open for criticism and interpretation, which is why I'm tempering my conclusion somewhat. So that's just a brief overview, and there's a lot more detail in that study. It's mimicking, I hope, what you would have done with your discussions with your partners. Hit the highlights. You're not going to be able to cover everything, but the main message and any main conflicts you might bring up and address. So, with that in mind, let's look at the even paper. And what I am drawing out here first is what I consider to be the main figure, and it's pretty small. I would have made it bigger, but I add text to this afterwards. I've prefaced this slide a little bit with some points that I think are important. But first and foremost, I'm leading with what I think is the main figure, and so this removes some of the mystery. Does anyone want to take a stab at what is the message of this paper? What seems to be the main effective exercise here? Yeah, Don.
But at the public health dose, it had the greatest effect of treating mild to moderate.
Okay, the public health dose had the greatest effect in treating mild to moderate depressive symptoms. So what's the public health dose?
Public health dose is 17.5 kcals per kilogram per week.
17.5 kcals per kilogram per week. Okay, that's good. Does that mean anything to any of you? It doesn't really mean much to me. I don't know what that means. If I had weight numbers, you could figure out kcals per week, and we have a better sense of what that is. 1,000 to 2,000 kcals per week is like the CSEP guidelines. Yeah, Leanne? Yeah, the public health dose is the general guideline. These are the American Heart Association, or no, not the American Heart Association. One of the American Association's guidelines. They're similar to the Canadian guidelines, but it's their public health recommended dose. Yeah, what I did is there are BMI numbers, and so I estimated an average height for the population at 1.6-ish meters. And then using BMI, I back calculated what weight should have been. And then at 17.5 kcals per kilogram per week, that puts it to about 1,300 kcals per week. It's a little convoluted, and I'm assuming the same height or similar height across the board. 1.6 meters, some people are shorter, some people are taller, but we'll leave it at that. It's around 1,300. No less than 1,000, no more than 1,500 probably. Anything else that you want to talk about in this figure before we get to the study at large?
There was a little difference between the low dose and the control group.
Little difference between the low dose and the control group. Absolutely. Is there any difference between the low dose and the control group?
No significant.
No significant difference. Okay, so statistically, no significant difference. And even looking here, the values are somewhat shaky. Or not somewhat shaky, are somewhat in line. 11.1 and 11.3 are the scores in each group. Fantastic. No major difference between the low and the control group. What else is of interest in the study? Low dose didn't really do much. Public health dose is where it's at. Let's start with Sadie.
I thought that it was interesting that they did all of this exercise in like solitary confinement almost.
Right.
Because they were trying to disprove, or not disprove, but at least confirm that exercise was actually giving the therapeutic effect rather than the social aspect of the previous study.
Exercise done in solitary, no people around, no participation, because there's a large social element to depressive symptoms also. So this is evaluating exercise as a monotherapy. Maybe what I should have done is had you hand in all your summary sheets before we went through this, but this will be a gimme. It's the introductory week. Exercise as a monotherapy, which, so this is really the low watermark. This is worst case scenario, perhaps. If you add group exercise, you add exercise outdoors, the idea of green exercise is gaining some traction recently and helping to improve mood. This is probably the worst case scenario. Whether the low dose responds, we're not sure. Whether there's a larger effect of the public health dose, we're not sure. I think what we know for sure, what I can confidently say, is that the adequate volume of the public health dose is required. You need to have at least that much volume because the low dose doesn't show any effect for depressive symptoms in individuals with mild to moderate major depressive disorder. And that's only in improving HRSD scores, Hamilton Rating Scale of Depression scores. You see the delta here as well because we have baseline shown as a line across the top and the largest drop with the public health dose. But what's a big problem about how baseline is represented? And I kind of hinted to the even groups as I went through to look at this quickly if you hadn't, but
Not everybody did have the same baseline score.
not everyone had the same baseline score.
And also, the public health dose group had a lower baseline to begin with, kind of similar to the first study that you showed us.
Okay, they had a lower baseline to begin with, did they?
Slightly.
Slightly, like you know, kind of seen on the graph, but there's pretty.
Okay, so you're looking at the line graph, figure 2, which not everyone has. Is that right? Okay, it's slightly lower, within maybe a point. Yep, I'd buy that. Anything else about the baseline scores for those of you that looked in depth? Maybe somewhat lower in the public health dose, and that's why we have this extra benefit. Granted. I think a big red flag with this study is when you look at that table or look at that figure and you see 16 to 17 as a rating score, and you don't all have the papers in front of you, and then you look at the baseline characteristics table, the mean Hamilton Rating Scale of Depression score at baseline, 19.3, 20.5, all mid to high 19s and low 20s, which is not 16 to 17, which is not this. Why?
Would you do this at later in the trial? Like this
Yes.
might be like mid-trial or something when the therapeutic effects are being experienced?
So my interpretation of this, and it's very hard to weed out the details, the baseline characteristics were generated at a screening visit. 19 or 20, really high scores at a screening visit. After everyone had been admitted, they did initial values and then started the intervention. So initial values are 16, 17. Between the screening visit and the initial value section, drop by 3 points. No intervention yet. So again, that kind of speaks to the intangibles of maybe there's just some element of hope or something we're not understanding. Now you're taking actionable steps as a person with major or moderate depression towards seeking treatment. Maybe that in itself is empowering and helps to reduce these scores. It's not all about exercise, even though we try to control it as much as we do by having them exercise in a solitary room.
Was
Yeah, Aaron.
the baseline measurement taken after the 2-week run-in period or before? Because they did do a
Right.
2-week
I think it was before.
exercise trial where they tried to see who could stick to the exercise.
Like appropriate dosages.
That is an excellent question, and I don't have that answer offhand. If I was pretty sure it was before the 2-week lead-in, which is why it seemed to raise some red flags. If it wasn't, if it was after the 2-week lead-in, that's a great explanation as to potentially why there's a decrease already. Yeah. Yeah, I think we covered all the main points that I wanted to get at. Public health dose, by far the most effective. Low dose doesn't seem to do much. One thing we're missing that I haven't shown here, it's not a major point, but they also separated out frequency, 3 versus 5 days. Anyone want to speak to frequency? Kristen?
There was no significant difference between exercising 3 days a week to 5 days a week, like in the public health
Right.
information.
So when you clamp the amount of exercise done, the volume's the same. Frequency makes no difference. You just do more shorter exercise bouts or fewer larger exercise bouts. They both work. So it's really up to whatever you prefer as an individual engaging in exercise, as long as you get the amount, the volume of exercise shown here. Roughly 1,300 kcals per week. Okay, good. Exercise is effective. And that, by the way, was 12 weeks, so that's a pretty nice long duration study, longer than most. Yeah, Rosanne, question?
I think even paper, like when you're saying that it's the screening, is that before everything else that they did? So they screened them, the baseline was like 16 and then per study?
3 times. I think.
Yeah, there are 3 screening visits to get at the ineligible people, and some of the screening involved, are you depressed? So are you a candidate for the study?
So that was the 19 to 20, or was that the 16?
That was the 19 to 20, and then the 16 comes later. So something happened in the screening that improved the scores, or maybe they had practice and they answered them more accurately, or when they knew it was being recorded, it's all self-report, maybe they underreported, who knows. But there is a difference in the screening process. Yeah.
So how do you control for something like that?
How do you control for something like that?
Just because like of all the things that it could be the reason that it went down 3 points, how do you?
Well, that question is there a way to screen less, essentially?
Yeah, I guess.
And I think because of the rigor of the study and needing to find people with an appropriate depressive level first, that also have the abilities to endure exercise and commit to 12 weeks. I don't know if there is less screening. Possible? I'm not sure. I don't know the answer to that. But you would have to shorten the time between whatever the baseline measurement is and the start of the study. You need to get rid of any time where things can change that aren't controlled for, in theory. It's a good question. So we have this potent effect of ongoing exercise. Just briefly, sorry, let's go back to this one. How was adherence? Anyone talk about or notice adherence in this study?
Was really bad, particularly for the control group. I think there was like a 40% adherence rate, so 60% of them dropped out, and they already had really initially low
Sample sizes.
Right.
So we kind of question whether that control group was representative or adequate.
Okay. If it's not representative or adequate, what does that mean for our interpretation? If too many of the control group dropped out, low adherence and control, what does that mean for this interpretation if they are removed or some individuals in the control group are not being included?
I think it questions when you compare exercise groups versus control groups and the difference between them if that control group was not adequate to be compared to that, because isn't that the whole point of experimental design?
Absolutely.
To a control group?
To have an adequate control group where you can measure an effect versus control is the idea behind this intervention study. So if you don't have that appropriate baseline, does that invalidate this?
We said it impacted internal validity a little bit.
Okay. Impacted internal validity. What is the most likely scenario for this impact? Now, this is theoretical, this discussion. It's a tangent. I'm not going into too much detail. What is the most likely scenario for why these people dropped out, Keegan? Or maybe another point?
I was going to say, for me, you have to wonder if the people that dropped out, people who weren't getting any benefit or felt there was no benefit, and the people who stayed in, people who felt they weren't going to get a benefit anyways.
People that weren't getting a benefit might have left.
Yeah.
Okay, Aaron?
The people, none of the people in the study were blinded to what group they were in, so if they knew they were in the control group, they weren't receiving what people thought would be an
Right.
effective treatment, so they dropped out.
Right, no one's blinded, and so if you think you signed up for nothing, then you're not really encouraged to stay in. Absolutely. Hard to blind exercise versus control. Was that the point that all of you were bringing up? All 5 hands? Yeah, absolutely. I would like to see personally what the baseline and initial characteristics were of those people that dropped out. I'm wondering if maybe they were quote unquote more depressed, if their scores were higher. If that's the case, then maybe this should actually have a more positive message. Maybe low dose did help. I'm not sure. Maybe the values in control should be higher. But it's speculation. I don't know. Aaron?
I know that they did say that the dropout rates, or the adherence was not significantly associated with a lower HRSD score.
Okay. Good. Okay. So I missed that point. Adherence is not associated with a lower HRSD score, which I assume also means it's not associated with the score period. Also not a higher score. Yeah.
It also mentioned that adherence rates were similar to other studies that have previously were dropout rates for medication studies.
Okay. Adherence rates are similar. And that brings the second point up as a devil's advocate kind of caveat. It invalidates or lessens the internal validity. But if you want to represent the population, you want external validity. And so they talk about the intention to treat analysis, which is if you were a person in the population that felt depressive symptoms and you engaged in one of these activities, you'd be subject to all the elements of living a free life in the world. And so maybe you'd be discouraged, maybe you'd drop out. Maybe this is actually reflective of how these treatments would be received in a less controlled real-world scenario. We try to make this a monotherapy. We try to standardize. The academic rigor is undeniable. We need to control for everything. But maybe there's some benefit here to increasing external validity in analyzing the data in an intention to treat manner. So even including all the people that dropped out, well, they would have dropped out in the real world anyways. Given that, how do these doses stack up? So maybe this is the most applicable to the population at large. I'm not sure. Nice discussion. We're running out of time. Let's move to paper 2, the odd paper, which I was hoping would seem like it picked up after the first paper. Maybe you have an effect of exercise or medication or a group, and now we want to see that external validity. We want to move into a free-living individual, normal lifestyle, back at home, not controlled. Is there an effect that carries through? So is there? Individuals in, yeah, man?
Well, there is.
There is.
So individuals in the exercise group basically show that the therapeutic benefit was maintained after like an extended period of time compared to medicated groups or combined exercise and medication groups.
Excellent. That's the first point that I have up here as well. Describing this main figure, this is 10 months after some intervention, and there are recovered, partially recovered, and relapsed, or people in remission versus not in remission. Exercise, far and away, more likely to have people in remission. Good. So whatever happened in that 10 months, if you were in the exercise group to start, if you were advised to exercise over 10 months, you're more likely to be in remission. So what happened in those 10 months? What can we say about these groups over those 10 months? Because now we're letting go of some control in those 10 months. We're letting people, we're leaving them up to their own whims. Yeah, Suzanne?
The medication group were more likely to take up their own exercise routines than the other two groups.
Yeah, so that's a potentially confounding factor. The medication group, a lot of them took up an exercise program. So what does that mean for these results?
It makes it really difficult to compare exercise to medication or combination of medication because it seems like the medication group itself is just could be like a hybrid of
So
exercise and medication.
the medication group is essentially combination number 2,
Yeah.
right? Okay, okay. What do we know then about medication as a treatment or in helping to maintain remission status in follow-up? Can we say anything about medication specifically? Yeah, Sarah.
Well, only 26% of participants that were taking medication continued to take it when the test was over.
Okay.
Yeah, so I think that for them that was probably less effective. They were less interested in continuing it versus with exercise. Only 6% of participants ended up taking medication and had lasting effects.
Okay, so the medication group, not only did some of them take up exercise, a fair chunk, about a third, stopped taking medication. So is the medication group a medication group? It seems like no. Yeah,
Well,
Leah?
yeah, I think that part of the reason that people in the medication group stopped taking it was because they just switched over. They didn't combine it. They just totally made the switch.
They just totally made the switch. Yeah. And from the research point of view, from a study point of view, that's not what you want to have happen. Obviously, you want to maintain your control and measure the effects of these 3 different groups, but from a patient-focused point of view, is that a good thing or a bad thing? And is there anything in the study that can kind of lean one way or the other, that pushes you one way or the other? Yeah.
Say that it's a good thing. And near the end of the study, they talked about how I just lost my train of thought.
Okay, it is a good thing. I'd agree with you there. And they do bring up a point about the likelihood of remission with those individuals that exercised, regardless of what group you're in. Did anyone catch that?
Lower rates of remission, it looks like, for both of the exercise groups or the groups that involved exercise in their treatment.
Lower or higher rates of remission?
Lower.
Lower rates of relapse.
Relapse, sorry.
Yeah.
Right.
Higher rates of remission for any group that included exercise. And even if you take out the individuals in the medication group that started an exercise program, so I had this point as well. Half of the medication participants started to engage in exercise. Yes, absolutely. The things that correlated with remission were Hamilton scores at the start of follow-up, so at the beginning of the 10 months, and the time spent exercising over the 10 months. And when you controlled for the Hamilton scores at the start, when you controlled for all variables, the exercise time spent is the only factor that correlates with remission. If you were in medication, if you were in the exercise group, nice proportional increase in remission rates with more time spent exercising. Even after controlling for baseline scores, time spent exercising made you more likely to be in remission, regardless of group.
Is that per exercise bout or total?
That's total time.
Total time.
It doesn't include intensity, I don't think, but we're assuming moderate, and that time spent equals more volume. But do more exercise, more likely likelihood of remission, regardless of the group that you're in, medication or combination. Yeah, sir.
I just remembered what I was going to say.
Okay.
They talked about how also with exercise in comparison to medication, that exercise gave you a sense of like pride and accomplishment.
Yes.
Feeling like I did something about my mental illness versus the medication was like, well, I had mental illness and I took medication to treat it.
Yeah. Exercise gave you the feeling of, and they use the word mastery, and I really like that word. Like you've taken control of the situation and you're not subject to the treatment, you are the treatment, which must be so much more empowering than just using medication. Absolutely. Okay. Fantastic first attempt at discussions. We'll probably keep something similar, but I'll let you know on Tuesday if it changes. Tuesday we get into Alzheimer's disease, which is a really fascinating topic. We'll talk about exercise and Alzheimer's, and then I do have new papers already. They are posted on Moodle. Take a look. Okay?
Are those for next Tuesday or next Friday?
For next Thursday. Yeah. Papers are always Thursday. Preamble on Tuesdays.
And it's the same groups.
Same groups. Yeah, the pairs might change. Same groups, though. I will take all of your summary sheets and peer evaluations. Let's do peer evaluations here, just face down if you don't mind. Thank you.